Yes, good morning and welcome back. For those of you who may be just joining us, welcome to the Achieve 2020, the 13th Annual Health Current Virtual Trade Show, Summit and Trade Show. I'm pleased to be selected to introduce the first participant-led session of the 2020 conference. The session is entitled EMS Use of Health Information Exchange on 9/11 calls and in Treat and Refer programs. For the next 45 minutes, we will learn how 4 community fire medical programs are using data in their systems and patient data that they receive from Health Current as they provide care in the communities. As we go through this program, we'll have 4 different individuals presenting their programs. And as we go through, if you have questions, please enter those in the chat section and we will address those at the end. At this time, I'd like to introduce our 4 speakers, and then we'll turn it over to them to present their programs. First, I'll introduce Jesus Rivera. Jesus is the battalion chief and paramedic for the Surprise Fire Medical Department. Today, he is division chief over the department's medical services and transportation divisions. And in this role, Jesus is responsible for providing training for all members of the department on treat and referral options, transportation services, and emergency medical service delivery. Jesus has been with the City of Surprise for over 19 years. Jesus has been involved in the Surprise Fire Medical Behavioral Health Community Medicine Program since its inception in 2015. He is a partner in the grant-funded West Valley Community Paramedicine Program, and he participates with the Vitalis Foundation's Treat and Refer webinar series, which promotes Arizona's Department of Health Services Treatment and Refer Recognition Program. Jesus is associate degree in paramedicine and is currently attending a program in public safety leadership. Next, I'll introduce Paul Lucy. I'm sorry, Paul, I always have problems with your names. Luisi. Paul is the fire chief of the city of Goodyear and has served in this role since 2013. He has also served in a number of other leadership roles in the city of Goodyear, including an interim deputy city manager, the deputy fire chief, and a battalion chief. Paul has over 32 years of fire and EMS experience with public safety organizations in Massachusetts, New Hampshire, and now in Arizona. Paul has been designated the fire chief officer by the Center of Public Safety Excellence and is also a certified public manager. He earned an MBA from Franklin Pierce University and a Bachelor of Science degree in Public Administration from Roger Williams University. Our third speaker then will be Brent Burgett. Brent is the Deputy Chief of Emergency Medical Services for the Mesa Fire Medical Department. In this role, he oversees a staff that provides daily support for over 400 emergency medical care technicians and paramedics in the Mesa. Brent has been heavily involved in community care programs in Arizona for several years. He has worked with several advanced practice providers, licensed crisis counselors, and a team of administrators in developing a community care model for the city of Mesa, for which they were awarded a $12 million CMS Innovative Grant. Brent has a Master's of Administration from Northern Arizona University and a Bachelor's in Communications from University of New Mexico. Our final speaker today will be Natalie Becker. Natalie is the Community Services Outreach Coordinator for the City of Tucson Fire Department in their program for the Tucson Collaborative Community Care Program, known as TC3. This program works to replace or prevent 911 calls by connecting citizens that are in need of services to appropriate community organizations. This aids in keeping emergency service personnel available and in service for more sensitive or time-sensitive calls. Natalie has been with the Tucson Fire Department since 2016, and she brings a decade of social work and community services experience to the department. In her role, she works with hundreds of community organizations throughout Southeast Arizona to build relationships that will ultimately improve the service for the most vulnerable in the region. Natalie holds a Bachelor's of Science in Public Health from the University of Arizona, and a Master's of Homeland Security and Public Health Preparedness from Penn State. That's our panel for today, and what I will do now is turn it over to Chief Rivera and to Chief Luisi to start their presentation.
Great, thank you so much, Mike. Good morning, everyone. Jesus and I will take you through our presentation. We're going to talk a little bit about our community programs. We'll talk about treatment refer, our connections with the HIE through Health Current, and obviously our community paramedicine program as well. So next slide, Mike. So one of the things that we worked on with our city councils in our region was really to understand what community paramedicine meant. So what is it? And really for us in the community, in the fire service, it's a coordinated effort to take care of our patients that would otherwise use the 911 system or emergency departments to help solve their medical needs. We really wanted to go out and identify those vulnerable populations that were having to use the 911 system to help figure out their medical needs. And it is an evolving model, and while it's, I guess, interesting to say that or phrase it that way, I really believe it is an evolving model because each community should really help define what community paramedicine means to them. And you'll see that there's 3 different models here today that we'll talk about, and you'll understand how each of those reflects the needs of the community. Next slide, Mike. So in this program, Goodyear Fire Department and Surprise Fire are working with United Healthcare on a community paramedicine project that we hope will fund us for the next 10 to 12 months through a grant program through their community initiatives. We also were working with Peoria Fire and Medical as well, but they unfortunately had to back out of this current grant program. So Jesus and I are leading the charge for our 2 agencies in pushing this project forward. Next slide, Mike. So the city of Goodyear, just a little bit about us. We're about 191 square miles. So from north to south, we're about 42 miles long. For us, it's interesting because we're only about 12 to 14% built out, but there are segments of our city that are north of I-10 that are 80% built out. So we're a very young and growing city. So we have a lot of area to go, but we are have been recently ranked as one of the fastest growing cities in the United States. So that's something that our council is very aware of, and we want to make sure that we are bringing new and evolving models forward to kind of help solve some of these healthcare needs in our community. And now I'll turn it over to Jesus to take you through some of his slides.
Hi, all right, so very much like Goodyear, the city of Surprise is a growing community, population of over 141,000 people. We have about 110 square miles with a planned area of about 302 square miles. So a lot of land to cover, a lot of people moving into a lot of different areas with different needs. Majority of our call volume is emergency medical services at 78%. We continue to face an increase in growing population as well as a aging population. Sun City Grand is inside the city of Surprise. So we have a very diverse community with a lot of different needs. And I think community paramedicine is a very important program to our growing city. Next slide, please. So we work with the Health Information Exchange by setting up alerts. Any patient that is enrolled into the community paramedic program has an alert established to them. We submit them onto a patient panel. And so these patients that are in our program, if they go to a hospital, whether they're taken by emergency medical services or not, we get an alert as soon as they go to an emergency room. And if they're admitted to the hospital, if they're transferred, or if they're discharged, we have that information as well as access to their portal. So we'll receive the alert. We'll be able to reach out to that patient. at that time, schedule that appointment, visit with them and find out if they have everything they need, if they filled their prescriptions, if they scheduled their follow-up doctor's appointments, to find out whether or not they're following their discharge instructions. And then we'll continue to follow up with them there because of these alerts. This has been a tremendous help to our program and has allowed us to really keep our fingers on the pulse of what's going on with our community. Next slide, please.
As part of the coordination, we really rely on the HIE and our current our database that we have through ImageTrend to ensure that there is that care coordination with our patients. We want to ensure that we are taking care and addressing those social determinants of health, looking at their health history, their medications, other provider visits. Obviously, a lot of our patients are using the 911 system to solve their healthcare needs that should really be otherwise addressed outside of the emergency department. So whether that's their primary care physician, specialty physician, social health needs, or any other referrals. And what we're finding is our patients are just not going to those appointments. And so there's a lot of varied reasons why, but primarily it's transportation. But we want to make sure that our patients are going to the right resource for the right reasons. And this platform really helps us develop that care coordination for them. Next slide, please. Okay,
another program that we're working with the HIE on is the Treat and Refer program. Treat and Refer is defined as anytime somebody calls 911, but their situation, their illness, their injury does not require ambulance transport to a hospital. It allows us the opportunity to provide them with treatment on scene, referral to a alternate destination that would be able to provide immediate care for their needs. And this program was recognized by the Center for Medicare and Medicaid Services on August 26 of 2016. It places the emergency medical care technician, paramedics in Arizona in a category of other healthcare provider, which allows us to provide that service without having to provide that transportation for reimbursement to a hospital. We can instead provide it in place. Next slide, please. So some of the agencies that are in Treat and Refer, that are considering entering Treat and Refer, have a concern. They're wondering about Onscene Times, because on 911 calls, it's supposed to be an emergency, life-threatening, but there are some times in the percentage of calls that are not life-threatening. So we are able to provide an assessment and then spend the amount of time that we need to figure out what resource would be able to help out this patient. So since we started the program in 2017, we've had a decline in on-scene time. We average somewhere about 50 minutes, 48 minutes, 50 minutes in the beginning, and then decline down to about 23, 24 minutes overall. And that's just because the more we do something, the better we get at it. The more that we explain it, we can better talk to the customer about these options rather than just placing them in an ambulance and taking them to the hospital. We've also broken down the disposition by year. Over the 4 years that we've been conducting the service, we send a majority or refer a majority of the patients back to their primary care provider or specialist to follow up with their needs to ensure that they don't do have an emergency for a chronic illness, and that they do receive that follow-up care, which can help prevent them from getting into an emergency situation. Next slide, please. The way the Treat and Refer program works is it's activated through the 911 system. We respond out to the call. We do the evaluation, the assessment, the EKG, blood sugar, temperature, vital signs, physical, social assessment. And we try to identify what can best serve the patient's needs at that time. It may be follow-up at an urgent care, primary care, crisis response, behavioral health. It may be providing them with treatment, and maybe they want to stay home. We've also included telehealth recently as part of these services. There are a lot of employers that are offering telehealth as part of their insurance program, but we're also going to start offering as part of our 911 services, one of the options that we can immediately provide to a patient so they can receive immediate access to care, prescription medications without ever having to leave their home. We really are trying to just make sure that if they don't need the ambulance to a hospital, that they have these other options. And the nice thing about it is we do follow up with these patients. We use the patient portal to be able to find out if there was an emergency encounter, if they ended up going to a hospital or not after receiving treat and refer services. We conduct a survey through email. We do have some phone calls that go out and try to see if the patient followed up with those services, see how they felt, and see what their satisfaction level was with the service that they received. Right now, we have about 98% satisfaction. People are really excited about this service. They thought the only option they had was to take an ambulance to the hospital. And this has been a growing program that's been very popular with our community. The nice thing about it too, being approved by the Center for Medicare Medicaid Services, is the ability to bill for services. So we do receive reimbursement from Medicaid payers that we have contracts with. It allows us to receive medications, supplies, consumables, so that we can continue to sustain that service. Next slide, please. One of the newest things that we've added to the service, working with our electronic patient care record provider, which is ImageTrend, they have a service through a company called KNO2, which works with the care quality system to be able to import and provide a patient query on scene. Really, our providers have to enter a first name, last name, date of birth, gender, and then a postal code, and it really helps identify who these patients are. We had the ability to look up patients that we've had contact with in the past to be able to find history, medications, allergies, surgical histories, things like that. But with this patient query on scene, we're now able to import that into the record. So on patients that we've never met, that we've never seen, we can provide better care, especially if they're unconscious and there's nobody available that can provide us a history. This has been a game changer and is great introduction to advancement, enhancement, and the next level of services that we're providing. Next slide, please. Follow-up is a huge portion, as I mentioned earlier. Being able to have access to the health information exchange, we can find out when a patient has an emergency encounter, whether or not they followed up with a referred resource. Anytime we partner with a new entity, service within our community, healthcare provider, we suggest and recommend that they partner with the health information exchange so that they can hopefully provide bi-directional information so that we can share what we're doing on 911 calls and we can receive follow-up from what's happening in their facilities. We can find out diagnosis, procedures, medications that they're being prescribed. And one of the newest services that we've been able to work with is the COVID-19 alerts. That's been huge for us because we've been able to document exposures, encounters that we've had with patients, suspected COVID patients. And now we're able to document those that when our members get sick, we can document positive exposures. We don't know what the long-term effects are going to be of COVID-19, but it's nice to have the ability and have the access to document these records now because of Health Current. Next slide, please.
So just as we kind of wrap up, I think one of the things you'll hear from us today is that collaboration piece. And it is very important for us to collaborate. We are the gateway many times for patients into the Arizona healthcare system. If you think about fire-based EMS and EMS just in general throughout the state, we probably represent anywhere from 1 million to 1.5 million interactions that we have with our communities across the state on an annual basis. And many of those, like Jesus said, 78% tend to go to call 911 for EMS needs. And a lot of those end up being transported to the hospital. So we are truly kind of a partner. We're many times the gateway into the healthcare system. So the collaboration is the most important piece. And I think for future needs, we have to continue to work together with our healthcare partners and look for opportunities to support one another, whether it's through bidirectional information or any other way that we can support each other. And ultimately, what it comes down to is ensuring a safe environment for our patients. And now I'm going to turn it over to Brent to talk about Mesa Fire and Medical.
Thank you, Paul and Jesus. We're going to take a little bit different approach here. How Mesa Fire Medical Department is utilizing the services of the HIE are just a little bit different. So just a little bit of context. City of Mesa is 137 square miles. We have about, in 2015, 471,825 residents. You know, during the winter, we typically have about 85,000 winter visitors. With COVID, that may change. We really don't know what that looks like at this point. In 2015, we typically saw about 75,000 people that were 62 years or greater. Next slide, please. One thing I wanted to demonstrate, and I think we're seeing this across the valley, but from 2010 to 2018, you can see the Mesa Fire Medical Department. We're running about 85% medical calls, but you can see, as this graph demonstrates, that we're seeing an increase in call volume. Some years are greater than ever, or others. Sometimes we'll see, on an average, about 3 to 5% increase in call volume year over year, but we've seen some outliers and some significant increases. Next slide, please. One thing I just want to discuss and how we're using it, really there's two ways that we use it. The first, we are not using it on the fire trucks for first responders, but our medical care record, our reporting system has an alert that we can notify through our Fire and Life Safety Division. We can make a notification to Social Services Division that we have. And what those social workers do is they get these notifications, and what they'll do is they'll do follow-up visits with these patients. And when we enrolled in the HIE, our goal was for our Social Services Division to be able to follow up. So some of the value that they see is, if you see in the first value that they're going to get from it is they know when the patient's admitted and when they're discharged. So they can plan a visit within that discharge time frame to make sure that they're actually going to go out there, they're going to see these people, they're going to be able to knock on the door and be able to have a conversation with them. Without that information, they were making blind visits where they would go out, they'd knock on the door, they'd call, they wouldn't get a hold of anyone. But with this discharge information, it really allows them to schedule out their day and plan those discharge visits. Secondly, the transcripts were super important to the social workers. The discharge follow-up was important because they were able to look at the transcripts, determine what the discharge plan was, whether there was home health involved, what the prescriptions were, whether or not they were able to get their prescriptions. So when they show up, they have a plan and a discussion kickoff point. Next slide, please. One of the things that they recognized is when we were not part of the HIE, they would show up, they would ask for discharge follow-up or discharge paperwork, and they wouldn't have anything. So they really were relying on the patient to come up with all the scenarios or all the feedback that the provider gave them when they got discharged from the hospital. Typically it was inaccurate, and typically they weren't telling them that there was already home health care planned. So they would start to put plans in place, and something would happen to where they would have to eliminate that whole plan. Secondly, the way we've been using this, the health information exchange for our crews is the COVID reporting. To date, we've submitted 10,000 names to the HIE to determine whether or not these patients were positive or negative, and we've reported 167 positives and 818 negatives. And to Jesus's point, we don't know what's going to happen. We don't know a lot about COVID, and especially early on, it was hard for us to get this information from the hospitals because there's a lot of legal questions about whether or not they should be supplying that information to us. We were able to get it from the Health Information Exchange, and we were able to catalog the exposures that our crews were having with patients that were tested positive in the community. And that really provided a peace of mind for us to determine whether or not what it really looked like out there, how many people we were saying that were positive, and it was really helpful for our crews to get that feedback. Next slide, please. Okay, I'm going to turn it over.
Yeah.
Hi, everyone. Yeah, so I'll just go ahead and jump into it. Again, my name's Natalie Becker. TC3 here in Tucson, Arizona is probably a good combination of really what Goodyear and Surprise is doing and also what Mesa is doing. So I think it's pretty exciting to see exactly how these different organizations are really coming to a lot of the similar responses to those in need. So next slide, please. So before I get into the meat and potatoes of the presentation, I'm going to go over a little bit of the statistics of Tucson. So we actually have a population of 545,000, just shy of 546,000, with about 226 square miles to serve. And actually, interestingly enough, 19.3% of our community members are actually living at or below the federal poverty line. Tucson Fire responded to 89,872 calls for service in 2019. And TFD actually has 22 fire stations, as well as just under 700 firefighters to serve the greater community of Tucson. But here at TC3, Tucson Collaborative Community Care Program, we're working specifically to reduce and prevent those 911 calls. And obviously, similar to what Goodyear, Surprise, and Mesa have all said, that's accomplished through really consistent and intensive collaboration with community partners, because that partnership is where we get those individuals directly to the more appropriate resources than 911. The difference in our program is we are actually not a community paramedicine program. We're not providing medical care on scene. However, we do have a nurse and we are all EMTs, so we can intervene if anything critical is stumbled upon, but we're not providing that care. Tucson's pretty blessed with a large variety of community organizations that have a lot of funding and a lot of people really willing to help. So by actively navigating towards those resources and getting our vulnerable community members to the resources that already exist, we're able to effectively reduce and now prevent those 911 calls. So this isn't just better care for our clients. I'm sure if any individuals here are listening and they're either in law enforcement or fire service, you know those 3 o'clock toe pain calls can be a little frustrating at times. And so we're getting those individuals to their PCP. We're connecting them to, sorry, I'm having a little technical difficulty here. We're getting them directly to the services that they need and are able to get them the care that they want. We've done this partially by partnering with Tucson Medical Center. It's the largest nonprofit hospital in Tucson, and they are the ones that have provided us with nurses and a case manager, and this is where our access to HIE was actually initially formed. It's through the hospital, specifically the nonprofit, that they said, you know what, Tucson Fire, you can go ahead and get on board. And then let's see, so TC3 actually is currently serving 200 individuals. However, we have served over 1,500 individuals since its inception in 2016. Next slide, please. So to the left here, we have a heat map of TC3 clients broken down by the wards in Tucson. Interestingly enough, you can see in the darker areas that this is where TC3 clients live and where they're being impacted. This is partially information that we've been able to pull from HIE and specifically getting out into the community. We can be better prepared to serve them once we knock on that door. We don't have to do an initial investigation and an initial phone interview. If we walk in, we have eyes on the situation and can relay that back to all providers in this individual's world. Now, like I'd said earlier, the 19.3% of our community members that are living in or living at or below the federal poverty line, we were actually able to map out poverty levels within the city of Tucson, and our clientele, our hotspots fall directly over that those findings. So we're recognizing that people who are experiencing poverty are more likely to respond to medical emergencies in a different way than what individuals who have access to insurance, primary care physicians are going to. They're calling 911. They're calling for those emergency situations that could have been addressed with preventative care in a doctor's office. And so, like I said again earlier, we collaborate actively with all of our partners. You can see here we've had a number of different scenarios. We're working with animals, working with housing, etc. And the beauty of this is, again, with HIE, we're able to relay the information that we see in the field to those that are providing the care, as we're not providers. And it paints a whole picture so that this individual can get the services they truly deserve. Next slide, please. So how do we specifically use HIE? This, when we were able to get on board at the end of 2018, I believe, was life-changing for our organization, because we were finally able to pinpoint where people fall through the cracks. If the hospitals weren't communicating with the fire department, or there wasn't an accurate scene size up relayed once the individual's dropped off at the emergency room, or there's home health organizations providing behavioral health care or a nutritionist, those individuals were not speaking. And by TC3 utilizing the HIE, we could gather that information, and with a release of information and consent from the client, are able to share on their behalf to make sure, again, that whole picture is being presented. So we're gathering insurance information on these individuals before we're even hitting the front door. We're getting the notes specifically from the primary care providers, the emergency providers that are providing care to these individuals, med reconciliation, discharge planning, any medications prescribed, so that if an individual comes home after an emergency room visit and is then discharged, and they go home to an environment that does not necessarily fit the description they gave their discharge nurse, then we're able to reconcile the situation, contact the emergency room, and deploy all resources. So when it comes to med reconciliation, can I get one more click, please? This is what we were doing. This is exactly from the field, where we'd go and find bags of individuals' medications and situations where it's like, what are you supposed to be taking? Thanks to HIE, we know what they've been prescribed most recently, and we aren't going through bags and bags of old or expired medications. And those two black bags, in fact, are also filled with expired medications. Next slide, please. So with Tucson, understanding that we can only do so much. Again, we're not a community paramedicine program. We're running a lot of calls and we're getting beat up on occasion. But HIE has allowed us to really get into the big picture of the clients that we serve. Everyone gets in this field because they want to help. And HIE has allowed us to help even more, be more efficient, be better when we are serving our clients and our patients. It's been able to connect us and make us more credible in the community also, as we're able to provide information to other organizations that are going to be able to provide the care that Tucson Fire is, that surpasses what Tucson Fire can do. The big one for us is the contribution to wraparound care coordination, because again, this is where we see people fall through the cracks, and that's where the 911 calls start coming through. And we want to keep our crews in service for those time-sensitive calls. So HIE has made us a more efficient team that has in turn contributed to a better department. When COVID came out, or when COVID became an issue, we were starting to get those results. We were getting the information we needed. We were getting tested. We were giving home delivered meals and dropping off dog food and cat food, which is simple, but we're seeing oftentimes in these notes when nurses are denoting that individuals are scared or anxious to be at the hospital because they have a creature that depends on them. So it's simple things like that that bring a peace of mind to our clients and really extends what Tucson Fire can do for our community. Next slide, please. if there's any further questions on that, that's my contact information. HIE has been a great component to our program, and we are so excited to be a part of this. So thank you so much.
Oh, and thank you all for, these are great programs, innovative, and the communities obviously are benefiting from these, all the citizens and all of our healthcare friends, provider friends. At this point, we have about 8 minutes or so left for some questions. I've got a couple I want to ask while we wait for the audience to submit theirs. And I'd like to start with Jesus, if I could. Are all of the fire medical departments in the state doing treat and refer, or is it a limited program today?
Yeah, so that's a great question. As you can see, there's a variety of programs out there available. Treat and refer is available to everybody in Arizona through the fire organizations. It's just a matter of whether or not the program is implemented. They may have challenges getting things started. There are a few steps that are required, such as becoming a recognized agency, establishing contracts with different payers within the Medicaid access program, and then having a billing mechanism, which not everybody has if they don't have an ambulance service, already have some type of billing service. So the biggest piece to that too, I think, is trying to get more payers on board beyond Medicaid. So I think with next year, ET3 starting up is going to bring Medicare on board to a very similar program to treat and refer, and then getting some of the privates involved as well. You know, we want to do what's best for the community. We want to be able to provide them with the best service and the best options, but sometimes it requires some the availability of funding to keep a program sustainable. And I think that's where we're meeting that challenge. But I know that we're continuing to work together. We appreciate HealthCare hosting us and allowing us to share our programs and stories here, so that we have the ability to reach out to more people and to communicate and share our story and have that option. But with COVID, we've seen more agencies become recognized and start to provide treat and refer services for COVID-like symptoms. So I think we'll continue to see that grow, and eventually everyone in Arizona will become a treat and refer agency as part of the standard of care.
Okay. We've had a few questions come in from the audience. I'll read the questions and then look for hands to go up on volunteers to answer it. I'm not sure what some of the abbreviations are here, but what is the value proposition with outsourcing BMLS services to third-party contractors, and how does that impact community paramedicine? Anybody, any thoughts on that? I'm not familiar. What we will do with these questions is do some follow-up and get back to the individuals who submitted, and actually to all of you with responses to that. Let's take a look at the next one. Have any of you ever considered having physician assistants, nurse practitioners, or physicians on the ambulance to provide one-stop care instead of a referral?
Hey, Mike, I'll take that.
Yeah, Paul?
That's a great question. This is actually our second pilot that we've done with community paramedicine, and maybe Brent can jump in because they've also had experience with this during their CMS grant. But one of the feedback that we got from our participants, so the medics that were actually working the street, the biggest thing that they found was not a need for a mid-level practitioner or a physician. What they found the need for was a social services person, so a licensed social worker and a medic would almost make the best or perfect community paramedicine team. And I think probably some of the things you heard from Natalie as well is kind of what they're seeing down in Tucson. But we just didn't really see that there was any benefit to having a mid-level or high-level practitioner with us. And I don't know if Brent wants to jump on because they had experience with that in Mesa.
Yeah, so So in Mesa, we did with the CMS grant, we spent 3 years, we were funded at about $12 million a year, or over 3 years. We had nurse practitioners, but when we wrote for our CMS model, we learned in our initial trial phase that having a nurse practitioner was beneficial for very specific calls. But what we found is we were starting to utilize them as behavioral health services as well. So that's when we incorporated a licensed crisis counselor. We found that those two together worked very well because some facilities that we were dealing with would not see a patient without having that primary care level services. The example I have is we had somebody cut themselves. They did require a couple sutures, didn't necessarily need an ED visit, but they did need sutures. To be in the crisis moment, we were able to suture the patient with the nurse practitioner on scene, call for the licensed crisis counselor, and have them arrive, do a point of care assessment, and then get them into behavioral health services. So they had their sutures, they had their antibiotic taken care of, and the facility took them. Now, we were able to do that because we had a $3 million a year grant. Those are high level services and they come at a cost. So there is value at the street level, we found. It's just a matter of being able to put together a sustainable model.
And if I could just piggyback off of that, when we were looking to revamp what our team was specifically going to look like, the nurse practitioner, multiple nurses came out, and our group found that it was really more of the people in the field that were actually just talking to people and connecting with them and understanding that 40% of our individuals that we're encountering have some sort of behavioral health or mental health concern, that a BHT actually became so important for us, someone who's trained broad range in behavioral health and able to deploy those crisis services well.
Okay. Well, I think we're coming to the end of our session. I really appreciate Natalie, your time, Jesus, Brent, and Paul. Been very informative, great. I've been working with a number of you for 3 or 4 years now, and really have learned a tremendous amount about what the fire medical programs are doing. And Health Current is absolutely proud to be able to be a small part of those programs and to help you and your people. Again, we thank you very much. And at this point, we'll turn the program back over for the next session. Again, Natalie,
Thank you.
Paul, Brent, thank you very much.